Well, good morning. So excited to be here today as we kick off Migraine Headache Awareness Month. As we talk through the whole month of June about things that are really important to our patients. And you may notice that we're doing this a little earlier this year. And it's really because when you go into May, mental health awareness is so important and it's so important to our patients as well. And so joining me today, we're really excited to have Dr. Richard Lipton with us. I don't know that you need a lot of introduction, but tell people what you do in case they're new in this community.
Sure. Well, thank you for inviting me. I'm a professor of neurology, epidemiology, and psychiatry at the Albert Einstein College of Medicine. And I also direct the Montefiore Headache Center. So I've been treating people with headache disorders for almost 40 years now
That's amazing.
lo- and also do a fair amount of research.
That's amazing. We're so honored to have you with us at American Migraine Foundation. You're so valuable and your name comes up often in this space. So thank you for giving us a few minutes and talk to people a little bit about why is it important to talk about depression and migraine?
There was a time when I was reluctant to talk about depression
Mm.
and migraine because I feared that some of the stigma of depression would rub off on migraine, and I worried that migraine was already a highly stigmatized disorder.
Mm.
But the reality is that migraine has a lot of comorbidities. And when I use the term comorbidity, I mean a condition associated with migraine that occurs with greater than chance frequency. And of all of migraine's comorbidities, depression is one of the most common and one of the most disabling. About 15% of people have comorbid depression.
Mm.
Of people with chronic migraine in the general population, about 30% have depression. And in my clinic, maybe 50 or 60% of people with migraine have depression.
Wow.
So part of the importance is that it's depression and migraine are such frequent fellow travelers.
Yeah. That's got to be hard though, because I imagine if you're someone with migraine and, I've only been in this space for a short time, but one of the things I hear a lot is people don't realize how debilitating it is. They don't really realize how many social events you don't get to go to, or your kids are going on to practice and you're in bed. Is it sometimes hard then to recognize, is it migraine causing the depression or depression causing migraine? Or do you hear that a lot, almost of which came first? And what do people do about that? Like really recognizing when is it depression?
Right. So, obviously migraine is defined based on headache and then the associated symptoms, nausea, vomiting, sensitivity to light, sensitivity to sound, and sometimes aura. Depression is defined by mood features, having a loss of interest or pleasure in your usual activities, being sad or blue or down in the dumps, and so forth. So the definitions are quite different. And I think experienced neurologists who treat migraine assess depression symptoms in everybody they see with migraine, but think of it as a separate problem. Now, it is the case that the relationship between migraine and depression is bidirectional. And so we've done population studies where we identify people with depression who are free of migraine. And when we follow them along, they develop migraine at an increased rate. And we've also identified people with migraine who don't have depression. And when we follow them along, they develop the other disorder at an increased rate. So the relationship is truly bidirectional. It's not that migraine causes depression or that depression causes migraine, but rather that each condition predisposes to the other. And it's important to say that we've now identified a group of genes that increase risk of both migraine and depression. So the relationship is in no small measure genetic and biologically based.
Wow, that's huge. And I imagine, and I've heard these stories that people are in bed for hours at a time. So sometimes even loved ones are like, are they depressed or is it they're in bed because they're maybe having headaches? Is that sometimes tough in the clinician space to try to figure out, to really kind of separate the two and understand how to treat them?
So when I see a patient with migraine and depression, generally my approach is to treat the migraine first. And in some people with migraine and depression, if you do a good job treating the migraine, the depression may lift. So we published a paper in JAMA Neurology just in the past few weeks where we showed that if we took patients with migraine who also had depression, diagnosed using DSM-5 criteria, the most rigorous criteria for diagnosing depression, and then treated them with fremanezumab, which is one of the new CGRP targeted monoclonal antibodies. We showed that in people with migraine and depression, not only does fremanezumab make migraine better, but it also substantially relieves the symptoms of depression as well.
Wow.
And we showed that in most people, migraine improved before depression. Now, we've previously used treatments that target both migraine and depression, but generally, there are a number of antidepressant medications, but not all antidepressant medications work for migraine. So tricyclic antidepressants like nortriptyline and amitriptyline work for both migraine and depression, and a relatively newer class of medications called SNRIs work for migraine and depression. But those are drugs that cross the blood-brain barrier, get into the brain, and directly treat depression and directly treat migraine. The reason I'm so excited about the fremanezumab study is that fremanezumab doesn't really get into the brain, and yet it makes depression better. So that suggests, at least in some people, treating migraine can improve both migraine and depression in people who have both disorders.
Yeah, that's amazing. One of the things I wanted to ask you about is like if you're a person watching this and you're struggling with both migraine and depression, what are the expected outcomes? You've given a little bit of that in what you were just sharing. What are the expected outcomes? Can treating the migraine first must be that must help a ton if you're in bed because you're also in pain. But what can a person expect if they're sitting there going, I just don't know what to do. I have both. I'm exhausted. What can they expect?
So, in most people who have migraine and depression, effective treatment can make both disorders better. Now, it's sometimes the case that we can treat with a medication and behavioral interventions that work for both migraine and depression. So that could include certain antidepressants, or now we know even the CGRP targeted therapies can make depression better. Oftentimes, you know, behavioral interventions work. So cognitive behavioral therapy,
Mm.
progressive muscle relaxation, mindfulness-based stress reduction, those behavioral methods work in slightly different forms for migraine and depression. If someone has depression as their most prominent feature and migraine as a less prominent, less disabling feature, then I may treat the depression first and not the migraine. And, fortunately at headache subspecialty centers, we have health psychologists on the staff, psychiatrists we refer to. And so, although I'm a professor of psychiatry, I'm not clinically boarded in psychiatry. So, sometimes if the depression is prominent or if the depression doesn't respond as I expected to treatment, I will refer to a psychologist or a psychiatrist to help my patients.
For the first time feeling depression symptoms, should they go to their neurologist for that, or should they try to seek a practice that maybe like yours has multidisciplinary physicians there? What if I think I'm from a rural area. Do you go look for a psychiatrist, or do you wait and just run it past your neurologist first? What's your advice about who they should seek help from?
Well, so honestly, I think people with migraine or depression, or people who have both disorders, migraine and depression, can often start with their primary care doctors. And the most widely used medications for depression are drugs called selective serotonin reuptake inhibitors, or SSRIs, and Prozac, Paxil, Zoloft are the most widely used drugs in that class. And most prescriptions for SSRIs are written in the primary care setting. Now, SSRIs are not great migraine drugs, but they are great drugs for depression and anxiety. And so, honestly, I think people should start in primary care settings. One challenge in primary care settings is that the behavioral approaches. So we have, as I said, health psychologists on our staff whose career is primarily focused on migraine and depression and anxiety in people who have all those disorders. And the behavioral approaches are really effective as well. It's easier to get a medication. We actually do have an online portal that was made by Dawn Buse, who is one of our health psychologists, who many people in the migraine community know. And that offers a range of behavioral interventions for migraine, but it includes progressive muscle relaxation. It includes mindfulness-based stress reduction. And so because it's difficult for people to get access to experienced health professionals, because insurance coverage varies a lot from person to person and place to place, the online approaches under the supervision of a primary care doctor can be helpful. And the dawnbuse.com website is free. And I imagine the American Migraine Foundation has some websites with these approaches available as well.
Absolutely. We'll make sure to put that in the chat too, and make sure people know how to utilize those resources for this discussion. So I could talk to you all day about this because I'm super passionate about mental health and how it affects people as well. As we're going into MHAM month, and have caregivers who are watching this, or support teams watching this, could be a neighbor. I mean, we get emails all the time from a nephew, a grandson saying, I want to help my loved one with migraine. What can you do if you see someone struggling with both migraine and depression? What can you do to encourage them to get the help they may need?
So there is a very simple screening tool called the PHQ-9. It was developed by Robert Spitzer, who was one of the people who wrote the original DSM criteria for psychiatric disorders. And it asks questions like, over the last 2 weeks, how often have you been bothered by the following problems? Little interest or pleasure in doing things. And then the people choose from response options that range from not at all to nearly every day. You get a score, and then the score can be translated into minimal or no depression, mild depression, moderate depression, moderately severe depression, and severe depression. So having people take this simple screening test can be a good way to see how depressed someone really is. And my view is if they have moderately severe or severe depression, that requires at minimum a conversation with a primary care doctor who may elect to treat. For people who are in the moderately depressed range, some of those people may need a medical or a psychological intervention as well. But, the great thing about PHQ-9 is that it gives you a score that reflects how you're doing over the past 2 weeks. So you can take it repeatedly, see if you're getting better, see if you're getting worse. If you have mild depression and you're being treated for your migraine, I think it's appropriate to wait and see if getting your migraine better gets your depression better. But, PHQ-9 is freely available, widely used by primary care doctors. We have people complete a package before new patients, before we see them, and we screen them for depression and we screen them for anxiety. And we're very careful to say, and the cautionary note here, of course, is if you have migraine and depression, that's not dismissing your pain complaint. That is not saying, oh, we think you have a primary psychiatric problem. It's saying instead that migraine and depression are frequent fellow travelers, and we'll be able to help you better if we understand the full range of symptoms you're experiencing so we can address all of them. It's certainly not intended as a way of dismissing people, because what I do for a living is try to make people with migraine better. Yeah. And if they have depression, it's important for me to know about that, give better advice.
I love that you said that if they have depression, it's important to tell you, because I think so often people may just feel blue or they may feel down and then it lingers. And then they're like, gosh, this may be what depression is. So thank you for adding that in. One note I wanted to ask too, and you said this, but I wanted to make sure it resonates with people. It's important that survey you're taking, that people are actually asking the patient or having the patient take it, not go, well, my spouse feels like they seem like they're still enjoying going out to dinner. They should really have them take the test, correct? I just want to reiterate that and not do it for them.
So I agree that it's designed to be self-administered and not completed by an informant. Every once in a while, a patient will take a PHQ-9 as an outpatient and come in and hand me the form. And when they do that, but of course, if they do that, I really like it. It means they're on top of their own care. I would encourage people with migraine who are seeing a doctor to complete a PHQ-9 and bring it into the doctor's office. Virtually all neurologists, headache specialists, and most primary care doctors are aware of PHQ-9, and it was developed to be a primary care screen for depression.
Yeah. Well, I think the takeaway for me is to make sure too that you don't do it for your partner or your spouse, because they may really be struggling to get out of bed, getting themselves dressed, going out to dinner, going to social events they used to go to, and they may not necessarily willingly share that. So I really appreciate that they need to take it themselves as a patient and really be honest with themselves, because we need their support team to know what's really going on. So give some words of hope. As we're closing out this session, this is a hard session in the sense that I know people are watching this that are struggling with depression. Close us out with a little bit of hope in this space.
So I'll state one fact and then share my overall perspective on this topic. So we know that when people have migraine and depression and we follow them over time, that's associated with a greater risk of migraine getting worse. But the good news is that if you address migraine and address depression, they both get better. They often can get better in parallel. Part of the symptomatology of depression is a feeling of helplessness and hopelessness. When people have migraine and severe depression, they may feel that they are hopeless and that there's nothing they can do to improve their situation. And that feeling is almost always the depression talking and not a realistic appraisal. So, there is a migraine and depression cycle to some degree. The more depressed you get, the more isolated you are, maybe the more disabled you are by your headaches. And the more pain you have, maybe the more depressed you get. But the good news is that when you break that cycle, when the migraine gets a little better, the depression gets a little better, which helps the migraine get better, which helps the depression get better. So the trick is to ignore your feeling of hopelessness, realize that is the depression talking, and break that cycle and move from a negative cycle to a positive one where you can see improvement in both migraine and depression. And if you're overusing acute medications that make you worse, in that context, the cycle of medication overuse is often broken as well. And so when I see a person with migraine and depression, my goal is to get them to believe in the possibility of recognizing and then breaking the cycle and moving from a negative one to a positive one. And that's what keeps me doing what I'm doing. I mean,
Yeah.
People get better.
Yes. Well, we're so glad you do. We're so glad you're doing what you're doing. Thank you for offering that hope. We also want to encourage people that if you are feeling hopeless, reach out to your loved ones. Make sure you keep them posted. Depression is real. The comorbidities are real. And so we just want to offer that hope to you that it does get better. Also, we have a support group, a closed support group that's called Move Against Migraine, and it says sponsored by American Migraine Foundation. But that's a great group to know that others are going through what you're going through. And so we invite people to join that as well. We'll also put those links in the chat. Dr. Lipton, thank you. I can't think of a better way to start going into MHAM than to have this discussion. And we thank you for what you're doing for our patients and for your belief that there's hope. That's what it's all about. So thank you so much. And we just appreciate your support for all of our patients.
Yeah,
Absolutely.
that is part of the reason support groups are great, is that people at the beginning of their journey towards improvement can talk to people who have completed the journey.
Yeah.
And that provides more hope than anything that I can say, to see someone who's been where you are, who's made the transition from despair to control of both migraine and depression.
Well said. I think that's such good advice to remind people to do that too. So, and that's what we want to be here for, is to advocate for others and to give them that hope. Thank you for joining us. And we'll look forward to continuing to follow you on our journey too, as we learn more from the work you're doing. So thank you.
Well, it's a pleasure to be here, and thanks for the opportunity to share my thoughts.